So we have a really great morning. Eric and David and Nabil. We heard a lot about PD-1 inhibitors and checkpoint inhibition, and so we saw that data a number of times yesterday. And so Nabil instead will present some new data on some specific genetic subtypes of cancer and some things he's found that seems relevant and won't be repetitive. David DeNardo will start. His bio is in the book. I'll just add a small editorial here. We're always borrowing from what we find in other diseases, and there are a lot of similarities on a genetic and a stromal level with pancreatic cancer, where David really has an expertise. And particularly with regard to extrahepatic cholangiocarcinoma, I saw some overlap or some insights that seemed relevant to our focus here. So David kindly agreed to come and talk about what he's doing there. So it's my pleasure to introduce David DeNardo.
Thanks, Aram and the organizers for having me and for the opportunity to participate in this. So, as Aram said, majority of my lab actually focuses on pancreas cancer, but what we particularly focus on, so we're a tumor immunology lab, and we recognize the advent of immunotherapy. We also recognize that not all cancers and not all patients are benefiting from this. So what we really like to focus on is making immunotherapy work in subsets of patients or cancers where it's been poorly effective. So I've adopted this slide to include cholangio, but what I usually say is that there are multiple cancers that occur and have high incidence of mortality. There's only a few cancers where we're really, really poor at primary treatment. Example of this is pancreas and cholangiocarcinoma, where even if you're diagnosed with maybe the best possible outcome, localized disease, we still only have effective 5-year survival for about a quarter of the patients. That suggests that the treatment modalities that are effective in these other major cancers have not been effective when translated to cholangio or pancreas cancer, and we need to think of different treatment options. And as a tumor immunologist, I'm completely biased. This suggests we should try immunotherapy in these cancers. However, in the context of immunotherapy in pancreatic cancer, at least, these trials have been surprisingly disappointing, with no response to CTLA-4 in 2 different trials, and several trials with a very low response rate, at least in pancreatic cancer, to our best agent, which is currently PD-1 or Pembro, outside of a subset of 1% to 2% of patients who are MSI high. This suggests to me that we need to think differently about immunotherapy and approaching it in cancers like pancreatic or cholangio, and we should approach it in a disease-specific orientation. I love pathology. So when I think about how we might overcome this, there are 2 possibilities. There are not enough mutations in these tumors. They're not as antigenic as melanoma, not as antigenic as non-small cell lung cancer. But I make the argument that on the spectrum, there are a subset of patients that are just as predicted to be as antigenic, and on the spectrum, triple-negative breast cancer have a similar mutational burden and have responses to PD-1 where pancreas has not. And I would suggest cholangio has less responsive to PD-1 than we would anticipate. So maybe we should think about this differently. So we look at the pathology of the disease. So this is a simple H&E picture of cutaneous melanoma from a human. And what you can readily appreciate is that it's tumor cell stacked on tumor cell stacked on tumor cell with modest but limited stroma. This is a statistically average picture of pancreatic ductal adenocarcinoma. I'll show you cholangio in a minute. And what you can appreciate is that this is not the case in this disease. About 30 to 40% of the tumor mass is indeed malignant cells, but about 60 to 70% of the tumor mass is this desmoplastic stromal response. Now, this desmoplastic stromal response includes high deposition of extracellular collagen. This is like a fibrotic scar tissue. I would suggest that our body immunologically senses this differently than it does the melanoma picture I just showed you. And it has been proposed that this desmoplastic fibrotic scar-like tissue provides a barrier to both delivery of chemotherapy, but also potentially effective immunotherapy. In addition to collagen and fibroblasts, there's also significant, it's not non-infiltrated. This is not a cold tumor. I've discussed this with many many different investigators. This is not a cold tumor. It's actually highly infiltrated in most cases in our collection of tissues as well as others. But these infiltrates tend to be of innate immune lineages, such as CD68 positive macrophages shown here. So maybe not the high T cell infiltrates you might see in a melanoma. This is also probably true for a subset of cholangiocarcinomas. So I've lifted images from 2 different places. One is Aram Heasel, just to illustrate that this fibrotic stromal response, desmoplastic stromal response, is present in a subset of cholangiocancers, as well as a significant immune infiltrate by particularly innate immune cells. Here's a macrophage CD14 staining borrowed from Aram Heasel. So these concepts that I'll talk about today, and I'll present too, they may be applicable to other diseases. So this is how in the laboratory we think about the barriers to immunotherapy in fibrotic cancers. They're twofold. They are that desmoplastic fibrotic stromal response, which probably acts as an armor for the tumor, or at least creates a non-permissive immunologic microenvironment, which makes immunotherapy ineffective or less effective than it could be, even if the tumor is antigenic enough, even if the T cells are primed. In addition to this, and probably shared with multiple cancers, there's significant infiltrate by innate immune cells, which primarily are immunosuppressive in nature. So we feel that these are the 2 areas that you could target. Now, we're not the only people who have felt this way. There have been several targets developed. So first part of the talk, I'll just give you a brief vignette of some of our past and present research on targeting myeloid cells. I'll be very brief, but to try to give you a perspective on that can be used in other disease types. And then I'll talk about targeting fibrosis. So one idea is that maybe you could target these myeloid cells and reprogram the tumor microenvironment and then make immunotherapy effective. So we're not the only people who have worked on this. There's several different molecules. We focus on the 2 up the top. So the basic idea of this is you have a significant infiltrate of immunosuppressive myeloid cells. I like macrophages, that's what we study. And they turn off T cell responses. So even if you're able to come back in and reactivate the checkpoint on T cells, there's still a myeloid response blocking this. And this is their native biologic response. This is part of their wound healing program. When you wound yourself, you create a fibrotic scar, you turn off T cell responses so you can close the wound. And this is normal biology usurped by the tumor or utilized in the tumor microenvironment. So the clinical idea here is that you could target and reduce the number of these immunosuppressive myeloid cells. I show macrophages here. CSF1 receptor, CCR2 are the 2 places that we've done this. These are molecules usurped from arthritis, actually. They were designed to treat arthritis. And by this case, you might actually bolster the T cell response, come in with checkpoint, you might actually have more effective therapy. So we've done this in animal models. I'll just show you one of a couple different examples where we've done this. This came out a little bit fuzzy. But basically, this is a tumor burden change graph. If you treat the mice only with chemotherapy, the tumors still grow through this. If you treat them with CSF1 plus chemotherapy, it augments chemotherapy. CSF1 is deleting macrophages. And if you treat them with immunotherapy plus chemotherapy, we can actually restrain disease progression, but we don't get tumor regression. Knock out the macrophages, we get full tumor regression in a subset of animals. And correlating with this, we significantly elevated T cells infiltrating the tumors. So this is all published work. Sorry, cut off. But what I wanted to do is just highlight one piece of small data and then show you that this has been moved into the clinic in several different indications, suggesting that these ideas are at least tractable to clinical development. So CSF1 plus chemotherapy is in at least 1 trial. CSF1 plus checkpoint, this is targeting macrophages, is in 3 independent trials. There are only a couple of them that have a pancreatic cohort, even though we had shown it in pancreas. So we still suffer from the same part that you guys have. Getting trials for your cancer, specifically designed for your cancer, is difficult. And then there are some CCR2 trials ongoing and in planning. So I wanted to step back from that. So this is actually the past work. I mainly presented it to give you a perspective. You can target myeloid cells directly, and this might be an approach that is effective to improve checkpoint immunotherapy. But what I wanted to talk about today is repurposing maybe targeted agents. So one other thought that we've had over the years is you can target the myeloid cells directly. You can target fibrosis directly. There's several indications of this. And PEG-PH20, as it was discussed yesterday, molecule against hyaluronan, has had significant clinical efficacy, at least in phase 2 study in pancreas, suggesting it can strip the stroma and deliver more chemotherapy. But when doing these type of approaches, you might be treating the symptomology of the tumor rather than getting at its root. And wouldn't it be better, at least in theory, if we could figure out the molecular programs that are present in the tumor that instruct these profibrotic and immunosuppressive microenvironment, that create the microenvironment. And there would we get an advantage over directly targeting the tumor microenvironment. We directly target the tumor microenvironment, maybe the tumor cells themselves can adapt. We target the tumor cell networking, maybe we can create a target where we can, sorry, that's the target, where we can both target the tumor and the stroma at the same time and then come back with immunotherapy to clean up. This is the first molecule of that type that we've thought about. We chose focal adhesion kinase because it's already a cancer target. It's already developed for cancer indications because of its native pro-survival and migration invasion properties. But what we were particularly interested in it was its properties in promoting fibrosis outside of cancer. So this has been well studied actually in chronic fibrosis models in animals. And it's necessary, the FAC pathway, which is downstream of integrin signaling, is necessary for sustaining pro-inflammatory pathways that both generate inflammation in the fibrosis microenvironment, but also generate pro-fibrotic factors that sustain fibrosis. So this was in a non-cancer setting. We suggested that we might actually be able to look at, see if we can target FAC to relieve fibrosis and possibly immunosuppression in the microenvironment of tumors. So first thing, you should check whether your target, even if it's on in the mouse model, you should check whether it's relevant to the human disease. So we started in the humans first. We find is that total FAC is not a mutated antigen. This is not a protein you're going to find in the TCGA database. It's not overexpressed. It's not an oncogene, but it is chronically overexpressed on the protein level. So we find about 80% of pancreatic ductal adenocarcinoma overexpress this protein, and more importantly, the activation mark for activated FAC pathway, phospho-FAC, is activated in about 86% of pancreatic cancers. I bet that outside of KRAS that you won't do as well with a molecular targeted agent against an oncogene. So this is a protein that's highly overexpressed and highly activated pathway in this disease. So we also were interested in those two elements of the tumor microenvironment, fibrosis and immune suppression. So does high activation of FAC, the highest levels, correlate with immune suppression? Indeed, at least in a small subset of patients, what we found is when FAC is activated in the tumor cells itself, it correlates with reduced numbers of CD8 CTLs infiltrating into the tumor microenvironment, but higher numbers of innate immune cells. Here I show you two markers for granulocytes or neutrophils. What about fibrosis? Is FAC indicative of a higher fibrotic response in these tumor microenvironments? Same exact sort of analysis. We analyzed the level of FAC activation in the tumor stratified. We find that total fibrosis is modestly elevated. All of our tumors are pretty fibrotic in our tumor bank. And then in particular, collagen 1 levels are significantly elevated. So activation of FAC, particularly in tumor cells, corresponds with these two barriers to immunotherapy, in our minds at least. So let's move this into animal models. So the animal model we use is a genetically engineered KPC model. It has, excuse me, is a pancreas-specific activation of KRAS and P53. Actually, these two alleles are used by others for cholangio. You just change the driver. And we like it because it recapitulates many of the aspects of the human disease. It's a highly fibrotic model, as shown here by trichrome for collagen. It's the blues collagen. And it's completely non-responsive to dual checkpoint immunotherapy. So we're starting out with a model that completely does not respond. So if we can have some efficacy in this model, maybe we can move things forward. We tried a clinically developed focal adhesion kinase inhibitor. It's called 4718. It's already present in the clinic, could be utilized rapidly in this model. And we thought this is like intelligent by design, but it didn't matter. Thought we were being smart. We treated mice either early, treated mice either late. So early is when they had microscopic PDAC, and late is when we have an ultrasound diagnosed full-fledged half-centimeter tumor in the pancreas of these genetically engineered mouse model. Yes, it didn't matter. In both cases, we see that focal adhesion kinase can restrain disease progression and elevate survival in these animals rather dramatically. We find this is quite dramatic when compared to common chemotherapies, such as high-dose gemcitabine, one of our frontline agents, that has absolutely no effect in this animal model. So that was relatively significant to us, but what we found was that we're not actually inducing tumor regression. This isn't like turning off KRAS and KRAS mutated tumors. What we do is we reduce a plateau for a small period of time, then tumors eventually form resistance. But this plateau might create a window. If we can reprogram the tumor microenvironment at the same time, this plateau might create a window for immunotherapy. At least that was our thinking. Also, I should say these animal models are indicative of the phase 1 clinical results for a very similar FAK inhibitor, where about 41% of patients enrolled had stable disease. One of these patients was pancreas. I haven't looked whether one of those patients was cholangio. Sorry. So what about the tumor microenvironment? Because this is really our target here. What kind of activity can we have there? What we saw, and we were relatively strikingly impressed by this, is that even over short periods of time, focal adhesion kinase inhibition, which is acting on the tumor cells itself, actually reduces overall fibrosis levels in terms of total collagen density, as well as the number of activated fibroblasts marked by FAP or SMA. So we're stripping away this biologic armor around the tumors. In addition to this, we also looked at the suppressive myeloid and other T-cell infiltrates, and these are our findings. We did this in 3 independent models, and what we find is we significantly decrease the number of tumor-associated macrophages and granulocytes in the tumors. And in 2 out of the 3 models, we have a decrease in Tregs, but not the third. So I'm actually going to summarize a lot of distinct mechanistic data into this slide. So I apologize to the postdoc who's not here, because this is probably a year of his life. So fibrosis, it's not KRAS, not oncogenes activate FAK, but fibrosis itself, the stiffness of the matrix, as well as the integrin signaling activate FAK. This in turn activates STAT3 downstream of this and promotes several different cytokines to be highly expressed by the tumor cells themselves. They generate both immunosuppressive myeloid responses, CSF1, CCL2, CXCL2, as well as pro-fibrotic and fibroblast proliferation and ECM deposition through FGF and CXCL12. But what about immunotherapy? So that was the purpose of this. So I'll make a side point. That chemotherapy also doesn't work very well in pancreatic cancer, so if we can make an impact on chemotherapeutic efficacy, we'll also be happy. That will still be a win for patients. So we looked at that. I'll tell you immunotherapy in a minute, but I'll show you this at front. So we did the traditional combined FAK inhibition with gemcitabine. Notably, Abraxane is one of our frontline regimens, but Abraxane doesn't work. The mice don't tolerate Abraxane, so this is sort of how you model this. What we find again, so we're using a slightly different genetic model. We find again is that we see that gemcitabine has no effect whatsoever. FAK inhibition on this reduced time scale has a reasonable effect on survival, but they all end up in the same place. And then we can augment or synergize with gemcitabine. I only bring up this particular data. I'm an immunologist, so this is interesting, but not the flavor of what we do, because this was translated into a phase 1b clinical study combining a FAK inhibitor with Abraxane in pancreas, which is ongoing, and WashU's one of the institutions. So what about immunotherapy? Can we create a microenvironment more permissive to immunotherapy, and does this allow T cells to traffic into the tumors? So I cut out the T cells part. I guess I'll highlight it at the end. So this is using the same aggressive genetic model, and here dual checkpoint immunotherapy has absolutely no effect on survival. Again, FAK inhibition has some effect, but it's modest. When we combined it with checkpoint inhibition, what we find is that we can augment the overall survival of many of the animals. We see tumor regression in a subset of animals with long-term survivors out past 6 months, which at least in this genetic model is fairly impressive. I think there are 2 or 3 other studies that have been able to do this, but it's not a large number. Correlating with these increased overall survival of these animals, what we find is while dual checkpoint inhibition is absolutely ineffective of generating sufficient T cell responses in this poorly antigenic model to increase the number of CTLs present in the tumor, this is your average screenshot, 2, maybe 3, 4. FAK inhibition plus checkpoint immunotherapy, which generated some regression in a subset of animals, also had significant T cell infiltration in these stromal poor tumors, which is shown here by the red dots are the CD8s. Tumor cells are in green. We were pretty impressed by these responses, or happy about them. So we paired with medical oncologist. Andrea Wang Gillum is one of our lead GI oncologists at WashU to design a phase 1b clinical study, which is open. It's actually open to all GI cancers. For the dose escalation, it's actually combining Pembro, PD-1, FAK inhibitor defactinib, and we added in gemcitabine because in preclinical models we showed that made the therapy even more effective. We're safe through dose level 5. I think what's important for my interests are in understanding whether this biology, which we see readily in the animal, can be recapitulated in the human, both for proof of principle for this particular approach, but for approaches like it. So we've begun to do the biomarker data. Every pancreas cancer patient gets biopsied. All the rest of the patients don't have to be biopsied in the expansion. And in the dose escalation and in the expansion, all patients will be biopsied, pre and post. So this is what the first 3 patients look like immunologically. I think we have 5 now. We find as we measure T-cell responses, and what we find in at least 2 out of 3 of the patients, we can generate higher T-cell responses with this therapy. We can have higher activation of the T-cells in these subset of patients, and we can have reduction in Tregs. Now, 3 patients, I could do this by flipping a coin, so I won't make too much of that. But at least we can measure the outcomes of some of these therapies in pre and post biopsies, both in fibrosis, so we have cores for fibrosis, and as well as the T-cell response. So I hoped, let's see what I have. To set the stage where I think that you can target the tumor microenvironment where immunotherapy doesn't work. It might be that a subset of those patients just don't have immunogenic enough tumors. But there might be a subset, our theory is that there are a subset of patients where the tumors might be immunogenic enough to have a response to immunotherapy, but the armor of the tumor microenvironment might be preventing the efficacy of this outcome for those patients. I think there are multiple ways to target the tumor microenvironment. We could do this directly if we're doing that intelligently, target the myeloid cells. I think you could also target the stroma itself. As mentioned, there's a Pembro PEG-PH20 ongoing trial. I think if you can intelligently design your targeted therapies and evaluate them for their immunologic and, in our context, in a subset of cholangio, anti-fibrotic properties, you might be able to intelligently combine targeted therapies that you already have some efficacy in, where you're already giving a benefit in a time window to the patient with immunotherapy if these are designed. And this is one of the passions of my lab. Okay, these are the people that did the work. There's a talented postdoc that primed this. And then we have a large number of outside collaborators that help us. We're happy to put your name here if we have an interesting project. We're looking for things that we can do and where we can be impactful. And I think that's the end of my talk. Thank you.
Thank you, David. I think we'll move on to someone who doesn't really need an introduction in this group. Eric Tran is here to talk to us about his work. He's starting a new lab, and so we're excited to hear about what he has going on. So, Eric, thank you for coming. And in the back of the room, it will be Eric Tran's talk. Let's get loaded. Can we load up Dr. Tran's talk? Do you have slides? Well, any questions? I try to fill the time. David, can I put you on the spot and ask you a question while we sort out talks? We have a question from the back. Sure. Yeah. Well, yeah. Go ahead. David, you want to?
I think we have dual effects. So we directly measured vascular number, vascular permeability to try to address this question in terms of, and particularly with an eye towards chemotherapeutic delivery. I think because we have probably an effective so the route answer is that there is no actually difference in vascular density in terms of the CD31 count. I know that's a poor man's way of doing that. When we do drug delivery style, we actually get more drug into the tumor rather than less, which you might predict with this traditional anti-angiogenic. But we're doing 2 things at once. We're ripping away the fibrotic stroma, which also probably blocks vascular delivery at the same time as whatever direct effect it's having. It's possible. I'm happy to work with somebody to work at that.